I said I'm Jonathan Westall. I work for Martin Luther King Community Hospital in South LA. South LA is a very fancy way of saying Compton Watts. We don't like to say that anymore, but it's Compton, it's Watts. It is the poorest socioeconomic status in California. Like I said, it's an urban population. They have some farmland, it's a little different. But basically, here's an overview of where we're at. 1.3 million residents, that's our service area. We call it Special Population Area 6. Los Angeles breaks all the pieces of the county down, as Los Angeles is a massive county, into special population areas, right? Poverty rates, unemployment rates, always rank them on the lowest. The only thing that we kind of lead the county on is not too many people smoke cigarettes in that area. I don't understand why. Meth is a better choice, I guess, but no cigarettes. So 40% of our population has no high school diploma. So how do you get a job? How do you get insurance? How do you pay for healthcare? You don't. 30% earn less than $25,000 a year. So this is Los Angeles, right? So $25,000 a year in Los Angeles after taxes is $12,000 maybe. Bottom 7 percentile for social determinants, and then $14,000 is our per capita income. $14,000. That's less than a lot of people in this room's bonus. You know what I mean? So that's the population we're dealing with. Quick clarifying note, I don't work for the MLK that was shut down by CMS in like 2007. There was a MLK Hospital, was on the front page of every newspaper in the country. If you were in healthcare at that time, you probably know about Joint Commission coming down, pulling accreditation. So that is a vacant office building behind us. In front of us now is the new hospital, that's where I work. It's 131 beds. 131 beds. 131 beds replaced a 543-bed hospital. We have a 21-bed ED. That 21-bed ED sees about 400 people a day. So we're built to see 40,000. We see like 110, 115,000 a year. Tents were a big thing for everyone in COVID, right? Everyone out and got a tent and want to do the respiratory treatment. We've been doing patient treatment tents for 5 years. That is standard practice of care for us. Most of our patients never see a hospital room, or most of them don't actually even see a bed. It's chair treatment, or we call them alternative treatment spaces. So access is one of our biggest issues here, and as the last presentation, I'll touch on a little bit of that, where they talk about, he was talking about bringing healthcare out to the community. That's not really a choice for us, it's a mandate. So with a hospital that full, when we run at about 200, 250% capacity every day, we don't have beds to take in new patients. Most of our patients aren't insured. So transfer agreements are not a real thing either. It's very hard to transfer a patient who has a chronic condition and is not going to get better and is never going to pay the receiving system. So we end up holding a lot of patients for long periods of time and trying to help them manage their disease the best possible. Same with surgeries. We don't do any elective surgeries. That has never been a thing. I know that hit everybody's system pretty hard during COVID. First thing they said was shut down orthopedic and elective surgeries. We do about 6 surgical cases a day, and about 95% of them are diabetic amputations with an average age of 42 years old. So people are losing limbs to diabetes at 42, and that's a very normal thing in this community, which is wild. Life expectancy, 10 years shorter than California. Housing, healthy food, transportation, education, kind of all the normal social determinants of healthy here. But when we talk about going out into the community, it's not because we want to or because that's what the consumer wants. To be frank with you in the room, the consumer doesn't have a choice. We're the only healthcare system in the area. We're the only one that's going to accept them with no payment or no payment arrangement. So the idea that we're out there catering to a consumer, we do, obviously we like to provide a good service, but that's not at the forefront of the mind. It's getting care out to them. If you've ever been to Los Angeles, it's a massive city. Even if you might live 5 minutes from the hospital, it might be walking distance, it might be 3 buses, or most families don't have vehicles for the family. They have a vehicle that's shared between multiple families. So the idea that they can just come to the hospital when they need to is not a real thing. We have a street medicine team, a few other continuum of care programs where we send folks out to the community to treat these people where they're at. Large homeless population. On a personal note, I kind of thought that was crazy. We're going to go out and find like the homeless patients who aren't going to pay when we're already seeing 200%, 250% capacity anyway. But it ended up decreasing some of our admissions because these people are out there living with the disease already. So the idea that they were the EMS agents, the EMS ambulance bays are going to pick them up and bring them to our hospital anyway. There's no other receiving ED in the area. So the idea that we can go out and treat some of that sepsis or infections that are in the homeless patients first ended up being a lot better on the front end. Patient profile from 2021, 90,668. That's a drop from 2020. COVID, we actually saw quite a decrease in patients. We were essentially a large ED with a small inpatient hospital on the backside of that. So when COVID hit and the ED numbers dropped, we never really had large inpatient numbers anyway, and our length of stay was always longer than anybody's anyway, right? We talked about diabetes and the amputations there. Mental health patients, we usually are holding 20 to 27 mental health patients in our ED every day waiting for some sort of placement into a long-term mental health facility. Again, those are not a real thing, especially if the patient is uninsured or underinsured. So we end up holding them on 72-hour holds until they are released, and then we get them back 2 days later. There's no end goal to it. It's just kind of a cycle. So our COVID rates were pretty high. I said about 2 times the state rate. Most of that is because people hear Compton, they think it's mostly an African-American community. It's not. It has shifted in the last decade or so to a Hispanic community. Hispanic community has come in and kind of pooled resources between multiple families and purchased homes in the area that have traditionally been passed down through generations. South LA had large manufacturing plants and populations back in like the 50s and 60s where there was unofficial redlining in LA, but essentially different communities of color were pushed towards South LA. So folks bought homes there. They've been passed down through the generations. Now the Hispanic families have come in and bought up those homes. But what that leads to is you have 2, 3, and 4 families living under one roof. So COVID, one person in the neighborhood gets COVID, then the next person gets it, the next person gets it, and all of a sudden you have a family of 14 who all live in one house, and now everybody has it. Like I said, they tend to live generationally too in these areas, so you have grandma living with you, great-grandma living with you, so it was passed around. Like I said, top procedures, amputations, wound care, dialysis. We have a regular dialysis population that comes to our emergency department. They use the ED as their regular dialysis. They wait until basically they're in septic shock and they're about to die and then come in and get dialysis. They're not on a regular treatment regimen or program. Some of that is because we're considered a medical desert for California. If anybody's ever driven around South LA, there are no primary care physicians' offices. There's no money there. The docs aren't going to get paid. There are no, I saw a CVS Minute Clinic up here. Those are great. Unfortunately, most of those were burned down in the 92 riots after Rodney King, and CVS has not made a push to come back. Totally understand that. They lost millions and millions of dollars there. There are no clinics like that. There aren't, like I said, primary care physicians or follow-up care. We've looked at partnering with a couple different dialysis companies, but eventually it comes down to the numbers. You know what I mean? You can't make it work. When nobody has insurance and no one is going to pay, there's really no skin in the game for them. And it's hard to convince a large for-profit entity that they should come lose money here. So, like I said, homeless patients are a large population of ours, and mental health patients, right? So a couple of the indicators are the people who live in our area. Like I said, we talked about education, and is healthcare going to fix this? Probably not. It's kind of a whole neighborhood issue. If you're not going to go to school and you're not going to get insurance, there's no raising up through generations. The folks who live here are marginally worse than their parents were, who are marginally worse than their grandparents were, and marginally worse than their great-grandparents. Like I said, right about the 50s or 60s, the progression in the area of South LA stopped, and it has slowly worked backwards since. Which is not the norm, where most people strive to do better than their parents. Some of that is some of the social welfare programs have backfired in the area. When you've given everybody free housing for 3 generations, they don't understand that they would need to go out and get an apartment, or there's some motivation behind it. Same thing with food stamps through the food stamp program in LA. They've tried to revamp that a few times, but it just essentially became blank checks, and that obviously doesn't work. We talk about households that lack a motor vehicle. That number's a little bit deceiving. Like I talked about, saying your household has a motor vehicle isn't taking account that 4 families live there. So your household doesn't have a motor vehicle. 25% of your household has a motor vehicle, and the other families don't. So we have done these pushes to go out to the community. Like I said, Get Out, Recipe for Health is a big thing, where essentially the physician can write a prescription for food for a family. Usually, right now, it's limited to mothers with children under the age of 4, because like I said, we just don't have the resources to do it for everyone yet. But essentially, they get a fresh fruit package, they get cooking lessons, they get recipes. The patients can either come in and trade that prescription in, or we have a mobile delivery team that goes out and brings it to the home. It's good so far. 500 people, right? I said is the first target for the first 2019. That has gradually increased over and over again, and we just launched it specifically for kids at school to bring healthy meals to the school. Schools are supposed to provide that, but School lunches are hit or miss. So we provide them to the schools. There's 3 high schools and middle schools that are within like a 2-block radius of the hospital. So the idea is to start these programs here at the hospital and go out like kind of an onion, radius by radius, until we can eventually encompass all of Special Population Area 6. Street medicine, that's what I talked about there. There's a street medicine team. So what we did was take some of our basically line level employees. Most of the folks in that picture were either patient transporters, security guards, EVS employees, people who know the neighborhoods, people who know the people in the neighborhood, and partnering them with a doctor or a nurse or a kind of a MP or somebody to go out into the street, into the home, and provide that care. And it doesn't have to be anything crazy, just simple blood pressure checks or certain things that people need prescriptions or their medication refilled, where they're letting their medications lapse for months at a time because they don't go get it refilled. Partnering with some of these line level employees who know the neighborhoods gave us credibility. As you can imagine, the credibility of MLK was kind of shot after it came down and got shut down completely. And then followed up by that, to be frank, I don't look like the neighborhood, right? So me walking into the neighborhood saying you should do this or you should do this, there's a lot of distrust there. I've worked there 5 years, I've gone to plenty of the projects, plenty of the neighborhoods, and built a rapport with a lot of folks there, but at the end of the day, they trust people who are from their own community. So partnering with some of these folks, and like I said, the cost wasn't all that high because a lot of these are entry-level line folks anyway, with a medical provider to go out, it's paid back in aces across the board for that. USC does one, also too on Skid Row in LA. We've partnered with them a little bit. We try to keep to our own area, but kind of focusing on that. We roll out our second one coming up. I think in the next month or so it'll be out. We'll have it fully staffed. And this is mostly focusing on the folks who do not have a permanent physical address. They live in the area, but they don't count as the population for that area because they call it unhoused, the homeless population there. But these folks these are our 30-day admissions. These are our returns, which kill our, if you know what I mean, if you're already considered about your HCAPs, your metric scores, we get smoked on 30-day readmissions because folks are coming back every time it rains or every time it gets very cold at night, which I'm sure you have a few in your ED. We have 200 a day in our ED. So just warehousing people like that who don't actually have an emergency medical condition that we need to treat is a drain on the entire system. Well, wrong one. So that's kind of the end of the slideshow or the wrap up. But basically what I want to touch on is the last presentation we saw had a lot about going out, where people don't want to leave their home or they want to be able to do most of the services from home. That's the direction we're pushing for MLK, and I think it's been more of a necessity than consumer choice. Like I said, our consumers don't have a ton of choice, but bringing it out there, we're able to stop a lot of these minor issues before they became major. When MLK was closed by the federal government, there was 6 years where there was no hospital in the Compton-Watts area. The folks in that area who continue to live in that area, they're not going to receive care in Gardena or Torrance or some other close by city. They stayed at home and got sicker. So when they got sicker and sicker and sicker, and then when the hospital opened, it was kind of opening the floodgate. So that's a little bit on health disparity. Our focus is to build outside the walls. We want to get into kind of copy CVS's Minute Clinic, not to steal a trademark, but that kind of 1 minute clinic where they can be in certain areas or certain neighborhoods. Barbershops are a big focus, and the women's centers there to kind of target specific. So I appreciate the time today. I won't take up any more, but that's a little bit about South LA and health disparity build out.